so much for the kind introduction. I've been a part of the conference before, but only virtually, so obviously I'm very happy to be here in person. And thanks to Sanofi for making it happen. I will talk about, let's say, my usual topic, chronic GVHD. But this time, actually, I want to focus on the burden of chronic GVHD and what happens after chronic GVHD, so basically late and very late complications in relation to chronic GVHD. So this is going to be the outline of my talk. I will talk about survivorship in general, and then dissect it a bit to chronic GVHD, late complications, very late complications, and hopefully finish up with some of the new perspectives in how we can manage better these complications. So, first of all, we know that survivorship is usually referred as a term in patients who survive 2 and more years after transplantation. This is, of course, because we do transplant mostly for acute leukemias, and if they don't come back in 2 years, we consider these patients cured. Large registry studies and large initiatives, as this one shown here. These are basically 2 studies from the same initiative, 2 big institutions who made a bone marrow transplant survivorship study with many thousands of long-term survivors. Gave us some of the new information, although this information is now already a decade old. But today we know that patients who survive 2 and more years after transplant actually, in comparison to the normal population, have a survival of 80% at 15 years. Or actually, they die twice as more. This is a study that has been done in 1,500 survivors. And this is what you see on the left. And on the right, from the same data, but a little bit a different group of survivors, it has been shown that 2/3 of these patients have at least one chronic condition, and that's twice as more in comparison to their siblings. And what is very important, that those with chronic GVHD have a hazard ratio of almost 5 of higher incidence of all late effects. When it comes to causes of late death, then for the ones who live 5 years and more, it's mostly secondary cancers, cardiovascular diseases, but also late relapses and then back chronic GVHD and consequently infections. This is some more new data, and this is data on survivorship in children. Where this has been published only 2 or 3 years ago, again a large registry CIBMTR study, where a large cohort of children has been evaluated for a cumulative incidence of a first late effect at 10 years, and specifically in relation to chronic GVHD. And it has been shown actually that chronic GVHD significantly increases the incidence of any late effect, as you can see here on the left. So 43% in patients with chronic GVHD and 32% without chronic GVHD. And this is particularly refers to non-malignant late effects, as you can see here on the right, and without having an effect of chronic GVHD to secondary cancers, which is a bit contradictory from what we know before, but I will comment on it a bit later. So definitely chronic GVHD is a risk factor for non-malignant late effects after 2 years after transplant. And when it comes to different sizes of chronic GVHD, then it's more about extensive GVHD, severe GVHD, progressive and interrupted chronic GVHD, so previous acute GVHD, the GVHD that affects mucocutaneous and visceral organs as well, and in patients who are more than 12 months on immunosuppression. So this is actually what I wanted to comment when it comes to to secondary cancers. It is maybe not totally correct to evaluate late cancers at 10 years after transplant, because late secondary cancers are actually very late complications together with cardiovascular effects, and these effects we can see 10 years onwards. This is something that we call very late complications. Late complications shown here in the middle are the ones between 2 years and 10 years, and these are mostly endocrine complications, bone loss, and others. Also renal toxicity, so these are the main ones, and they are all directly or indirectly related to chronic GVHD. And of course, I'm going backwards, but then in the first 2 years, chronic GVHD is the one which is most important, because we know that most of the chronic GVHD, 95% of it happens actually in the first 2 years, and this is why we consider chronic GVHD as a delayed complication. I will first talk about chronic GVHD and its direct consequences in order to move on to late and very late complications as its indirect consequences. There are a few things that I would like to highlight here. First of all, we always consider chronic GVHD of protective against relapse. So is that really the truth? Well, again, large registry studies have shown that patients who have chronic GVHD at 1 year after transplant have worse survival, which is basically at the end what is the most important. And that is because, of course, the increased risk of transplant-related mortality. And some studies have shown that chronic GVHD is associated with lower risk of relapse, but this is a very nice study shown here on the right on 2,600 patients and published in Blood, where it has been shown that it's not the same if we talk about the early relapse and the late relapse. And actually, acute and chronic GVHD do not protect from early, but protect from late relapse, actually. And chronic GVHD does not add anything if a patient had already had acute GVHD. What is also important is the fact that we need to decrease immunosuppression as soon as possible in patients who do not develop GVHD, because this is what you see on the graph here. Discontinuation of immunosuppression in patients who do not have chronic GVHD is actually the only thing that then can prevent early relapse. But decreasing immunosuppression is something that we need to have in chronic GVHD in mind all the time, because it has been shown, and I show it here on the left, that patients who are on immunosuppression at 1 year after transplantation have, again, worse overall survival. And when managing chronic GVHD, although we always consider it an autoimmune disease for life, we have to have in mind two things. And the first one is this thing that I'm showing on the left. And the second one is that immunological tolerance in chronic GVHD, unlike in other autoimmune disease, will eventually occur, and clinical tolerance will occur. Therefore, we have to evaluate chronic GVHD systematically and periodically in order to calibrate or decrease immunosuppressive medications in order to allow disease to emerge before increasing the dose and until meeting this clinical tolerance. So in general, and for all the late effects, the lowest amount of systemic immunosuppression is needed. When we talk about direct consequences of chronic GVHD, of course, the most important or the worst one is lung GVHD. It's bronchiolitis obliterans, and we consider it a form of chronic GVHD because all patients who have BOS actually have chronic GVHD as well, although not all of them have had pulmonary comorbidity before. And when it comes to numbers in general, lung GVHD will occur in 6% of all transplant patients, but for sure it is something that we are scared the most, because it significantly decreases the mortality risk or increases overall survival, as shown here on the right. And for that reason, this is something that we always have to take in mind, that patients who have chronic GVHD have to be routinely screened, irrespectively of their symptoms, because we know that pulmonary functional test screening is absolutely crucial as symptoms occur when already this pulmonary function is severely decreased. And this is something that we know. We are all very well aware that chronic GVHD impairs quality of life of patients, but there are objective measures. This is a study, again, on a huge number of patients, 1,300 and more, who had been evaluated according to their chronic GVHD status. So, and as no GVHD are as resolved, and then mild, moderate, and severe. And this study has shown that patients with moderate or severe chronic GVHD really have worse quality of life, lower physical functioning, mental functioning, higher symptom burden, and more likely to be taking medication. And what is also important, that a huge number of patients will not be, with active GVHD, will not be able to work. And this is what we actually consider as going back to normal life, being able to work. Actually, as we all know, this is the first question that patients usually ask us before transplant: when will I be back to work? So when it comes to chronic GVHD and late complications, I think we are all very well aware of the bone loss and the complications of bone loss, which can lead to osteoporosis and vascular necrosis. And this is a very nice prospective study which was carried out to assess the bone mineral density in patients after stem cell transplantation. And in almost 300 patients, you can see that the bone density is actually lowest at 2 years after transplantation. This is why we have to actually start the evaluation of bone density or densitometry already at 1 year after transplantation, and continue it regularly, especially in patients at risk. And these are the patients with chronic GVHD who are on steroid therapy, on cyclosporine, who are inactive. And actually 2/3 of patients with chronic GVHD will have osteopenia. When it comes to other endocrine toxicities, this is something that is most burdensome for patients, especially young patients. We know that after myeloablative conditioning, almost all female and male patients will be infertile. However, there is some data, and this is a very nice, again, prospective cross-sectional study which was carried out to assess sperm production in long-term male survivors and published later on in Blood, which showed that there is a number of male patients that can recover spermatogenesis even after myeloablative conditioning, but that's only patients who are young, who are less than 25 years old, and importantly, who do not have chronic GVHD. So this is an information that is useful to be aware of. Hypothyroidism is also the next most significant late toxicity. It gets to a plateau very late after transplantation, as you can see here. This is why we evaluate thyroid function regularly. We should do it regularly, once a year. And again, a nice study from Bipin Savani and colleagues has shown that actually in the multivariate analysis, the prolonged chronic GVHD is a main risk factor for thyroid failure in long-term survivors, so both to overt hypothyroidism and to clinical hypothyroidism as well. We don't have to pronounce too much that renal toxicity is very significant in patients with chronic GVHD who take cyclosporine. There are other significant risk factors as well, but in the study that I mentioned earlier in children's survivors, actually when the late effects were separately analyzed, renal dysfunction was the only one that stood out as there was higher renal dysfunction in patients who had chronic GVHD in comparison to the no chronic GVHD group, although these numbers were not high. Unfortunately, when 10 years passed, it is not over for our patients, especially in patients who had chronic GVHD, because this is the time when it's time for very late complications, and this is something that is, of course, very devastating for us transplanters. When we talk about very late complications, it's about cardiovascular diseases, and the cumulative incidence of cardiovascular events is 22% at 25 years. They have twice more cardiovascular death than normal, and it happens at the median age of 49 years or at 9 years after transplantation. We know it's TBI that does the endothelial damage, but there is also some very nice data showing, and I have shown it here on the right, that when compared to controls, patients in acute and chronic GVHD, and we of course know it, have significant endothelial damage, which was in this study measured by blood vessel density in comparison to healthy controls. Definitely chronic GVHD is an established risk factor that also contributes to endothelial injury. When it comes to secondary cancers, they also occur, unfortunately, and that's the most devastating, to have a cancer in a patient who has already had one malignant disease. Although there are contradictory data, the objective measure for having higher rate of secondary cancer is the standardized incidence ratio, which is a ratio between observed and expected incidence. And rates for all these cancers, and I've mentioned only these ones, is high in comparison to normal populations. And you can see that in skin, oral, thyroid, and esophagus cancer, and that has been, this has been gotten from review of a huge set of data, is definitely chronic GVHD, and we have to have that in mind as well. So, after all this, how do we manage this patient? Well, I have been talking last days about long-term follow-up clinics. This is something that I think is crucial, because once a transplanted patient, it's always our patient. We have to see them for the rest of their life. This, of course, is not very easy. Follow-up of these patients is not always easy, not because of us, it's because patients don't want to always come to be followed up. And this is a very interesting study from BBMT in 2020, where you can see the cumulative incidence of becoming lost to follow-up by age, and it can be up to 30% in pediatrics and 13% among adult survivors, with predictors being the younger age, non-malignant disease, no insurance, being unmarried or having a person to push them to controls, and residing far from the transplant center. We have guidelines which help us manage these patients. However, what is new is that new guidelines have been done in this year and hopefully will be published next year. This was like a pan-world effort that I think many of you have been involved as well. And when we talk about being lost to follow-up, the new perspective that I want to definitely mention at the end is a digital health option that became attractive in the COVID era and really stands out as an option to bridge this gap. But digital health is not, of course, just telemedicine. Digital health is many things. We know that machine learning, I think there is even an AI talk tomorrow, which should be very interesting. Machine learning, this is a study that I like to show, is something that is also changing the perspective. This is an analysis of chronic GVHD patients which were stratified according to the NIH criteria, which analyzed by the AI, by the machine learning, revealed 7 different phenotypes, clinical phenotypes that we are not aware of, which could be stratified into 3 risk groups, which could then stratify overall survival, as you can see here on the right. And this could be actually easily reproduced like with a simple decision tree by a physician. which of course makes us speculate that we could use this kind of approach to predict late complications, have different risk groups, and maybe even have new strategies for prevention. Digital health is, of course, telemedicine, which can ease follow-up as well, and has potential to improve access to survivors in a cost-efficient manner. That has been shown as well. And there's also one attractive method that is attractive in the context of chronic GVHD, and that is remote patient monitoring, which can facilitate delivery of care, as this is the example of home monitoring spirometry via a wireless handheld device connected to a web monitoring portal, which was done as an observational study, and that was recently published. This is an example of a 56-year-old woman, and this study has shown that this kind of spirometry correlated very well with the spirometry done in a traditional way, and this high-risk patient had a good chance that this handheld spirometry could precede the real diagnosis of bronchiolitis obliterans, which we know is the most important GVHD form. So I think this was my last slide, and with this, I thank you for your attention.